there are new therapies that are coming along, but before those new therapies come along, is there any other unmet need that you can see if we have these agents that are quite powerful and will it continue to improve? What do you need diagnostically that's going to help you determine when therapies absolutely should begin?
Yeah, I think this is where clinical judgment still is very important, because we don't have a nice biomarker to say you now clinically are developing amyloid polyneuropathy or amyloid cardiomyopathy. It may be better in cardiomyopathy than polyneuropathy. So symptomatic onset and a battery of tests and a neurologic exam. But the neurologic exam is still very important in these patients.
So you're advocating at the moment that there be end organ changes before we actually have the capacity to treat?
Yeah, and I think, again, these are, for diflunisal maybe not, but certainly for these silencing drugs, $450,000 a year, I think we can't be putting patients who you haven't demonstrated they have a neuropathy yet on these drugs.
Michael, what's the biomarker we're missing?
Well, I think they're approved for hATTR neuropathy.
Yeah.
So you're a little bit restricted to what the label says. But if it were up to me, yeah, we'd be treating people very early. That's what I would want as a patient. But the costs and the other factors complicate issues.
So for all three of you, the question then is, if you have capacity to detect when the variant protein begins to misfold, would that tool be sufficient to guide you in instituting therapeutics? Akshay, what do you think about that?
Well, I think that might mark the beginning of the vulnerability to development of disease, but I think as been mentioned, I think one of the challenges is really not understanding exactly the nature of the pathophysiologic progression here. I think we have some broad models of what happens, but whether that step itself, and if we could key in on it, would be the signal of the timing of therapeutic initiation, I think is still a hard question to answer. You know, I can step back a little bit and look to my colleagues here, because I think for us, really the trigger to initiate therapy would be the onset of heart failure symptoms. It would be hard to argue to initiate therapy well in advance of that, given the data we have. But I think, you know, the challenge for us is that we often see these patients and don't recognize that they're there. And I think what I've learned today a tremendous amount is that the index of suspicion needs to be pretty high, and that there are some auxiliary clues in the clinical history and in the family history that we should try and integrate. And maybe those are our current biomarkers, really, the symptom onset and a detailed context analysis.
Well, I think one of the things that we have learned from these clinical trials is that the people who are earlier in the spectrum of disease seem to benefit most from the interventions, and that having a biomarker that would permit us to intervene early, I think is going to be critical, not only for cardiac disease where there's a huge burden of amyloid, but also in the neuropathy where there's less evidence histologically of amyloid burden, and maybe a little more toxicity from the oligomers and the aggregates that circulate. But it's been a real pleasure talking with you, Michael, Akshay, and Jim. You represent a huge amount of amyloid innovation, and I look forward to doing this again sometime. Thanks a lot.
Thank you very much.
Thanks very much.